Thank you, Professor Pandey. It's a pleasure to be such a distinguished group of the congenital cranial disinnervation disorders, which is a specialized thing that we talk today. I have no financial disclosures to make on this subject. As Dr. Pandey has said, DRS happens to be the most common congenital cranial disinnervation disorder. Clinically, just to start, all of us know that it is a condition which may present as an eso-tropic condition in which on adduction there is a retraction of the globe because of co-contraction and abduction is limited, or it may be an exo-DRS in which there may be an exotropia in the primary position, but again on attempted adduction there is a co-contraction causing a retraction and a marked upshoot and downshoot. Duane's retraction syndrome may be also known better as a co-contraction syndrome. It was first described by AIOC in 1879, later by Stilling and Turk in 1899. And however, it was later popularized by Alexander Duane, and that's why it's known by his name. And it may be still better to call Stilling-Turk-Duane syndrome. The frequency in the strabismus patients is about 1 to 4%. It is more commonly seen in females, about 60%. 80% of the cases are unilateral, and with 2/3 having a left predominance. Now, these two facts are very interesting, which have now been alluded to by Dr. Parsa's work. And DRS is included in a condition as we have talked about. What is that interesting work that I was talking about? By Parsa and Robert, they have shown that it is thromboembolism which is causing the Duane syndrome and other similar congenital cranial disinnervation disorders which are occurring in the 4 to 8 weeks of embryogenesis. The culprits are, one of them are thalidomide and misoprostol, which has been described by Marilyn Miller's work, and higher estrogen level and inflammation of venous thromboembolic events, plus the right to left shunting affects the left carotid artery more commonly. And this is the reason why we are seeing more in the females and more is the left preponderance appears to be there. Now, if we learn from this article, we will be able to understand the basic embryogenesis and the cause of Duane's and conditions like malnutrition, dehydration, alcohol, infections, trauma, ionizing radiations, antiphospholipid syndrome, and other autoimmune disorders which are affecting the pregnant lady during the first 4 to 8 weeks of antenatal development could be the cause of Duane's retraction syndrome. So maybe in future we are going able to prevent or reduce the incidence of this condition. When we do the imaging, we can see the missing 6th nerve. The bottom picture shows in a control both the side 6th nerve is there, whereas in the upper diagram you can see the missing 6th nerve on the right side in a case of a right exo-DRS. Huber has very nicely shown. So now we know it's a primary disinnervation here is involving the 6th nerve. It's a hypoplastic 6th nerve or hypoplastic nucleus of 6th nerve. And the secondary disinnervation is the abnormal innervation which is happening because of the nerve 3. He described 3 types of Duane's, the Huber type 1, which is 78%. And as you can see by the electromyography, it is seen that on abduction, the lateral rectus doesn't fire at all. In the primary position, again, the lateral rectus is not having much of innervation. And on the adduction, both the lateral rectus, the upper tracing, and the medial rectus are co-contracting. Now, this is the reason why there is a retraction and sometimes upshoot and downshoots. A type 2 Duane's retraction syndrome is 7% of population, and this is having some normal LR activity. But in the adduction, there is again a co-contraction, which is paradoxic innervation of the lateral rectus. The type 3, which is still less common, is type 3 is about 15%, and this would be seen when the LR and MR both are firing all the time during adduction, abduction, and in primary position. Disinnervations in DRS are a situation in which the 6th nerve is missing and the 3rd nerve is playing in place of that. Similarly, the synergistic divergence, there is an innervation which is instead of the lateral rectus is coming from the medial rectus, and that causes a synergistic divergence. The associations in the eye which can be seen are in the form of nystagmus, microphthalmos, but primarily which one examining person should always look into is crocodile tears, gastro-lacrimal reflex. That means when the child is eating or swallowing, he is tearing in his eyes. The other thing which may be easily picked up is the Marcus gun jaw winking phenomenon, which may be associated with Duane's retraction syndrome. And then in the fundus, the choroidal coloboma, hypoplasia, and morning glory disc can be seen. The systemic associations are in the form of cervical spina bifida, cleft palate, facial anomalies, perceptive deafness, malformations of the external ear, anomalies of hand and feet, and cardiac anomalies. Now, these things are the reasons that we see in these syndromes, all these association of the systemic that we talked about. In the common syndromes are the golden hour, the Klippel field, Wilder-Wank, Holt-Oram, Okihiro, DRRS, IVIC, or the oculo-otoradial Okihiro syndrome. Now, these are in detail, if you want to see, these are the associations, but these can be there. A Wilder-Wank is actually a combination of Klippel field with deafness and polydactyly, whereas a Holt-Oram has got associated cardiac anomalies. So, coming to the clinical part, the paradoxic innervation of the lateral rectus is the basic culprit or problem which we need to address in our management. So, in our management plan, what we should look in, according to me, is these 4 points. First is look whether it's an eso, exo, or orthotropia. Secondly, look for how significant is the co-contraction. This you will see on the basis of the retraction, which is the slightest sign, and marked upshoot and downshoot means there is a severe co-contraction. Third point is the force reduction test, which can be seen intraoperatively for both medial rectus and lateral rectus. And the fourth point is the LR activity. How much LR activity is there? Is it normal, subnormal, or not there at all? Now, in eso-DRS, when we are seeing FDT which is mildly tight for MR or almost absent, but there is a minimal co-contraction, then a simple LMR recession of 4 mm. Mind you, you need to do very little MR recession in cases of eso-DRS. If you do a little extra MR recession in the presence of a more moderate to severe co-contraction, it will lead to an iatrogenic synergistic divergence. And this usually when you suspect preoperatively, then you should combine the lateral rectus recession with a Y split whenever we are doing an MR recession. So this is an important take-home message. So in eso-DRS, minimal MR recession as required for the FDT. If it is tight, LR recession with Y split should always be added to if there is a significant co-contraction. If there is a very tight LR, a periosteal fixation may be done, but usually in eso-DRS we do not see this. SRT, VRT, and all can only be done if the co-contraction has been taken care of or neutralized. So if you have an eso-DRS in which the minimal co-contraction is there and FDT for MR is slight, then LSRT alone may be done to improve the abduction and correct the esotropia. So this is a planning algorithm which you can find in the Indian Journal of Ophthalmology, which we have published, which can be used for the planning the surgeries. People have talked about doing an LR resection, which is traditionally contraindicated. Ipsilateral LR should not be resected. This is what the classical books talk about. But a group of Stephen Kraft has said that you may do a LR resection of small amounts, but I would say one should better avoid that. Management strategies in exo-DRS could be Y splitting with LR recession, large or supramaximal LR recessions, or a periosteal fixation of LR or an extirpation of LR. So which one do you do and when? It will depend upon the primary position exotropia, the co-contraction severity, and third is the LR activity, whether it is normal or absent. If the normal LR activity is there, as you can see in this diagram of the patient, that abduction is almost normal. There is an exotropia in the primary position and the retraction is quite a bit. So in such a situation, one should do an LR, that is the left lateral rectus recession of about 12 millimeters. In this case, we did with a large Y split of 21 millimeters. And as you can see, the retraction and the upshoot and downshoot both will be taken care of. Mind you, the retraction is corrected by the recession of the lateral rectus, and the upshoots and downshoots are taken care of by the Y split. Little lateral rectus recession usually in homeopathic doses is of no use in exo-DRS cases. You have to do good amount of LR recession, and if the FDT is very tight and there is no normal LR activity, I would suggest doing a lateral rectus periosteal fixation to take away the lateral rectus which is having a paradoxic innervation altogether, and then the missing abduction can be improved upon by a partial vertical rectus transposition. Adjustable partial VRT can be done to give more controlled abduction improvement, and this video shows you how much improvement can be there in the right eye which was involved. The abduction is restored in spite of the periosteal fixation of the LR. This is a planning algorithm for exo-DRS cases, which again you can find in IJO. Ortho-DRS is a little more difficult game to tackle because the challenge is to correct the upshoots and downshoots, which may be significant, but still maintain the orthotropia in the primary position. Many strabismologists may avoid doing ortho-DRS cases for this reason. But when you have to do it, you should always do an adjustable MR recession or a controlled MR recession with an LR Y split so that you can retain the ortho positioning in the primary position as well as correct the problem that is there. To improve abductions in exo-DRS, nowadays we are doing a modified Nishida procedure, and this is showing you the pre-op and the post-op of a girl who had a lateral rectus Y split done, and after that we have done a modified Nishida to improve the abduction. Even an inferior rectus transposition can be done, preferably in cases which have a marked upshoot or a primary position hypertropia. This is what was done, and you can see the improvement in the control of the upshoot which was there. So to conclude my talk, eso-DRS cases, MR recession alone or with LR recession with Y split should be done. In exo-DRS, you may do a large LR recession or an LR recession with a wide Y split or a periostal fixation, and to improve abduction, you may do a PVRT or a SRT or IRT depending upon the pre-operative hypertropia that is there. And once you have neutralized the paradoxic LR activity. In ortho-DRS cases, one has to maintain the ortho position, so do an adjustable MR and LR recession with Y split. Thank you all.